Hello and welcome to this module around emergency first aid or basic life support. You're going to do wound management and pressure care. So part of this, I thought, well, actually, there's a lot of crossover with being a first responder, looking at different types of wounds and how we deal with those. And there's not much difference to when we become somebody looking at wounds. So I thought it makes more sense that we run through the emergency first aid syllabus, which is the full one-day accredited program. And then what we'll do, we'll look at wound management and pressure care also as a top up to this information. So we're going to build on the information that you learned from here. And that's because actually in wound management, there are wounds that you see as a first aider, so the very first steps to a treatment plan and a care plan, which is the aftercare. So we kind of got principles of a first aider into primary and secondary care. So we're going to start off with basic life support because that's the basic fundamental skills. As a care certificate assessor, you must be able to assess other people for basic life support. And equally, you should, at level 5, be an emergency first aider within your workplace. And you probably should be doing the 3-day advanced course on top, but again, risk assessments, etc. apply. So welcome to this module. I'm very animated about this subject because I've been teaching first aid since 28, nearly gone 30 years now. I've been teaching this subject. And in that time, not a lot has actually changed. And I'm all about the voluntary sectors and the Red Cross and St John's Ambulance. So for me, I love this subject, and it's what got me into nursing and social care from a very young age. So I'm hoping you're going to enjoy this session. So first of all, let's talk about the role of a first aider. We have lots of acronyms in first aid. So again, you're going to need a pen and bit of paper just to jot those down. And when we go through your training towards the end, I definitely will expect you to be able to reflect back on some of these, because at level 5, you definitely should be able to carry out the basic principles of emergency life support. So what's the role of the first aider? Well, you are normally the first person on the scene of an incident or an accident. So with anything, if we think about our reporting duties, the first thing we need to do is assess the situation. And we assess the situation by checking for danger. So am I or the casualty in danger? And we're going to make sure it's safe. We're going to look for those clues. So what happened? What caused this incident or accident? Do we know the history? What's the signs and the symptoms? So if we're in a dining room and we know that they've got eating problems, maybe they're choking, so we understand that there's a risk there. But if we walk into a room and we find somebody on the floor, then we might need to do a bit more detective work about why they're there, what's happening. As I've already said, protecting people from danger. So assess the future for danger. So is there going to be further danger there? Am I or the casualty going to be in danger whilst I'm performing this help? And finally, I'm going to get help. So if you're in a workplace setting, you may call your alarm system. If you're out in the community, you may shout for help, or you may call the emergency services. But again, recognize your limitations and think about the timeframes in which you have. You're going to need to prioritize the treatment. So this is triaging. And we're going to teach you some techniques for triaging as we go through this. So there's a couple of things that we can do there. Now, for me, when we look at triage, you've got to look at the most important thing down to the least important thing. And you must know how to triage a single patient and multiple patients. So we'll talk about that in a minute. You've already done your work around risk of infection control. So you know that you need to be maintaining good infection control procedures around body fluids and basic principles of health and safety. Know when to wear your gloves, think about decontamination, think about your aseptics if you need to do aseptics. You know, you're not in an on-street situation in a nursing or care home, but you may be in an on-street situation if you're going into people's homes. So equally, if you are going into people's homes, do you have first aid equipment? Now, the aims of the first aider, or what I like to call the job description, comes under 3 Ps. Now, you may have heard of this before or not. So the 3 Ps are preserve life. So at this point, it becomes the most prioritized thing that I'm going to do. So if I think about my treatment, if I think about triaging, if I think about multiple casualties, the one thing I'm going to do is think about preserve life. I'm going to prevent the condition from getting worse. So I'm going to look for signs of deterioration, or I want to stop signs of deterioration. And then finally, the bit that we all hope we get to, promote recovery. So here we're looking at making sure that the person is able to see signs of recovery. And you've heard me talk about recovery quite a lot. So what should we have to hand? Well, each building, each property, each service requires a risk assessment, and that risk assessment will determine the type of first aid kit you need. We know that first aid kits should be green with the white logo because that's our universal sign for first aid services. In a first aid kit, you'll see simple pieces of equipment. So gloves, facials for CPR, safety pins, you can do a multitude of things with those, micro tape or adhesive tape, your foil blanket, and again, if you go back to your epilepsy training, we talked about the foil blanket, great for covering up for dignity and privacy. We talked about hypothermia and the effects of heat loss. So what a foil blanket does is it keeps the heat into the person. So it doesn't warm somebody up. And that's really important to know about a foil blanket. It doesn't warm them up. It keeps the heat that they already have in. And we'll talk about that later when we look at the effects of heat and cold. Eye wash, great for obviously anything in your eye. Grit, scissors, because you may need to cut through to start CPR. Plasters, it's a given. Again, think about allergies, etc. Wound dressing, you want multiple sizes, so you need some small, medium, and large. Eye pads, remember, and we'll talk about eye injury later. Finger dressings, everyone loves a phalange incident, so if your phalanges are damaged, you're going to need one of those. Burns dressings, depending on what your policies are on these. Triangular bandages. Now, let's talk about quality of triangular bandages. If you're going to put a triangular bandage on, please make sure that you are putting on these nice cotton ones, not these paper ones. Quite frankly, those paper ones are useless. I mean, they're great for mobilizing a limb, maybe to the body, to the side, to bring feet together and legs together. Useless as a triangular bandage. I don't know whoever invented them. They just slip, and within 2 minutes, the arms from an elevation into a lower arm sling. So if you're going to do triangular bandage, go for the more high quality ones. Granted, they're probably 20, 30 pence more, but they're going to hold and they're going to protect the limb in which you're trying to look after. Wipes, so you should have gauze, and then bandages, either crepe bandages or just normal bandages, but the crepe bandage is a better one because they're much more supportive for putting limbs together and helping with compression. So we talked about different kits for different places. If you're a small organisation, you can see here, it gives you a list of the kind of things that you should have, medium to large. And then if you're out in the community and travelling, you've got yours there. And you're going to assess on low risk to high risk. So, for example, if you're in an office, it's quite low risk because not a lot can really happen in an office, versus food preparation areas or warehouses where you've got things that can cause injuries and cuts and other things. So equally, you may need to think about what are the types of things that you're going to have in a nursing home. So for example, you've got kitchens. So in those kitchens, you should have your burns treatments. You're going to have bigger pads for bleed, because if they chop a limb off accidentally with a knife, that's where you're going. Or you're going to have bigger burns because of those kitchen injuries. In the laundry, you've got more chemicals. So it may be the fact that you've got more saline washes and things like that to treat that. In the living areas, so where you're supporting people to eat and drink, you're going to have your choking packs. So the VAT packs, and what the VAT pack is, it's something you put over the mouth and you pump down and it removes the choking item. So just think about the environment and then the type of equipment in which you may need. But remember, you must be trained on this and you must be observed and you must know where they are. Now, regarding medication, so in a first aid situation, we're not allowed to give medication because obviously we're first aiders. In a medical situation, it's slightly different because you are trained under the Medication Act to dispense. So let's talk about that for 1 second. If I've got a patient sitting there and they go, I've got a headache, I don't know what to do, I'm in pain, or they're having a heart attack and they've got an aspirin and we can give those, then we can go to the EMR chart, we can look at the PRN stuff and we can give it. So if it's written up, we can give it. What we can't do is give homeo remedies under a first aid act. So in other words, members of the public that come into your service or people that you don't know, you can't give medicines to. Okay. However, they can purchase them and they can have informed consent and choice of capacity. That's very different, but we can't give them under a first aid situation. So when we have a first aid incident, we're going to do our primary and secondary surveys. So we're going to do our scene surveys, and under our scene surveys, we're going to consider things that we've never considered before. So you're going to go in, you're going to have a look around, and you're just going to check the environment. You're looking for what happened. What are the further dangers? Are you able to cope with the situation that you're in? What are the number of casualties? How many people there are needing your service? Do you need the emergency services? And what other help are you going to need? So you're starting to process all of this information in the back of your mind. You're going to do your primary survey. Now, in any incident, so if you go into a room, you find somebody on the floor, or you see somebody a little bit pale, we always do primary survey first. So in a nursing situation, it's exactly the same. We're not changing the rules just because this is the first aid course, it's the same rules. So our primary survey looks at DRAB. So danger. Am I or the casualty in any danger? Response. So for response, look, listen, feel. Hello, can you hear me? Can you open your eyes? So we're going to do the Glasgow Coma Scale, AVPU, alert, voice, pain, unresponsive. Hello, can you hear me in each ear, just in case they're hard of hearing? People may later and go, yeah, I can hear you, I'm asleep, go away. So give them a command. Hello, can you hear me? Can you open your eyes? Get the eyes open. If that hasn't worked, because maybe they're hard of hearing, pinch their ear or wipe your finger across the eyelash. If you see the eye twitch or they respond, then they're conscious. If they don't respond, at this point, we're going to say, I have an unconscious casualty. We're going to check the airway. So is the airway clear? So to check an airway, we tilt the head back, we extend the jaw, we look in, and we look in the mouth. The only thing that should be in the mouth is teeth, tongue, and gums. Anything else, tilt the head to one side, little finger, and scoop it out. Breathing. We're going to look, listen, and feel for breathing. So we're going to look for the rise and fall on the chest. So our eyes go, our ears go to their mouth. So we're listening. We're looking down the chest for the rise and fall, and we're feeling for breath on our face and on our hands where we're going there. And again, circulations or sign for life. So again, as we feel the face, it should be nice and warm. The lips should be a nice colour. If the lips are looking blue and we've got cyanosis going on, we know that there's a restriction going on there. So again, we can assume that there's some cardiac issue. So the primary survey is a static, this is universal worldwide, same principles. Doctor ABC, danger, am I of the casualty in danger? Response, hello, can you hear me? Can you open your eyes? Airway, teeth, tongue, gums. Breathing, look, listen, feel. Circulation, signs of life. Touch, check for cyanosis, and then that's our primary survey complete. At the end of that assessment, we will make an assessment decision. So again, think of SABAR, situation assessment, the background and recommendations. Am I going to start life support procedures, or am I going to do something else? So ultimately, at the breathing stage, if you have decided that there's no breath, so there's no breathing, and when we talk about breathing, we mean normal breathing, then we would start our CPR sequence. So we need to treat life-threatening conditions as soon as you find them before you move on. You might not get as far as C. So if you're already in a situation where you need to deal with breathing and all that lot, you must deal with that first. So catastrophic bleeding can be prioritized over airways. So if you've got limbs that are loose or that they're just pumping out with blood, we need to deal with that, and that could be direct or indirect pressure. So let's look at life-threatening conditions. So under airway, we're looking at vomit, choking, burns, asphyxiation, strangulations, and hanging. So if we haven't got a clear airway, we can't move on because there's no point. If the airway isn't clear, they're not breathing, we can't do anything about it. So we must prioritize those first. Under B for breathing, we're going to check those respiratory conditions. And again, that's another thing that we were going to be doing today. We're going to be looking at respiratory conditions. So asthma, crush injuries to the chest, infection, so pneumonia, things like COPD, collapsed lungs, poisoning, asphyxiation or aspirations, and then cardiac arrest. And then finally, we're going to move on to C. So cardiac problems here, so heart attack, heat, severe bleeding, poisonings, cardiac arrest, and anaphylaxis. So this picture of a gentleman down here could be a real typical picture of somebody who's having a cardiac, a heart attack, typical signs of going into shock, that pale face, blue cyanosis on the lips, blue around the eyes, a real giveaway that there is a life-threatening condition going on here. So signs of life-threatening conditions, pale and clammy skin, blue tinge to the lips, and that's cyanosis. So if you see cyanosis, we've got a problem, we need to deal with that straight away. Increase in the pulse rate. So again, checking the pulse, doing a visual pulse on there, on down by the thumb, or in the cardiac, or in the carotid, or alternatively, you may have your pulsometer that you pop on. And again, signs of nausea and vomiting. We know that if we feel nausea and vomiting, it's the body preparing to fight, so it shuts the organs down, and that's why we feel nausea and vomiting. So the increased breathing rate obviously produces low oxygen levels, so our pulsometer is going to start to drop. Lower breathing rate will then indicate a problem with the brain because the brain is not getting the oxygen it needs. The brain will then start to shut down and it causes the respiratory problem, and then we start hearing that distressed breathing or grasping, and that's called the agonal breathing. And we'll talk about agonal breathing shortly. And again, all of that is going to cause delirium and that confusion. So what we have is our early chains of survival. And early chains of survival has been around now for a really long time. So again, this isn't a new concept. But early chains of survival is recognizing deterioration, loss of life quickly, early CPR, early defibrillation, and then post-resuscitation care. So we know that the percentages and chances of CPR on street is quite low. What we're doing, we're keeping the body in a position, we're keeping the heart in a ventricular fibrillation position, so the heart's moving, so we can at least give that a shock, and that obviously gives them a better chance for survival. So the chain of survival is early recognition, call for help, early CPR, early defibrillation, and obviously better post-care. So let's look at the basic life support for resuscitation under the CPR sequence. So again, primary survey first, danger, am I other casualty in danger? Response, alert, voice, pain, unresponsive. Hello, can you hear me? Can you open your eyes? If not, shout for help. Tip the head back, open the airways, teeth, tongue, gums. Normal breathing, look, listen, feel. Call for help at this point because you know you've got an unconscious casualty, and ask for the AED machine, the external automated defibrillator. You're going to now check for your signs of life, and you're going to do your compressions. You're going to do 30 chest compressions and 2 breaths. So 30 and 2, 30 and 2, 30 and 2. We're going to be aiming for 100 and 120 chest compressions per minute, and the rescue breaths are optional. However, you should have your face masks and everything else there. When the AED machine arrives, obviously all you need to do for an AED machine is switch it on. All of the external automated defibrillators will talk to you and tell you what to do, so just remain calm. So again, primary survey, danger, response, airways. So again, you can see here, tilting the head back, extends the muscle in the neck, it moves the tongue forward, and it clears the airway. Breathing normally. So the breathing normal, if it's agonal breathing, that's not normal breathing. That's called agonal breathing. That doesn't count. And then circulation. So this is our primary survey. So in the first few minutes after a cardiac arrest, the casualty may be barely breathing or talking infrequently or noisy gasps. These are known as the agonal gasps and should not be confused with normal breathing. If in doubt, just start your CPR. So, let's see if that works. Okay, and then here is an example so you can hear and see what that looks like. Okay, bear with me, it just takes a minute for my page to load up. Hopefully that does. Okay, so that's not working. What I'll do is I'll send a different link for you to have a look at that, so not to worry. So sometimes a casualty can have a seizure-like episode, and that's where their heart stops. Carefully considering the casualty is breathing normally, so that's fine. So this is a link, and again, we won't worry about that. I'll forward these links afterwards so you can have a look at that. But it just looks like what a seizure-like episode is. So again, it's useful just to watch some of those examples of CPR. But you have got examples of CPR in the training sessions anyway. So automated external defibrillators, quite simply, you grab them, you open them up, you pop the pads on. You can't get it wrong because there's a picture on them all. You can see here on the top left and the bottom right of his rib cage. And that's so the shock is sent diagonally through. You just pop them on. And again, for a child, it's just in one place, front and back. So again, for children, slightly different positioning than the adults, but we're dealing with the adults in your training. So for children and baby, first aiders can use the adult sequence of resuscitation on a child or a baby who is unresponsive but not breathing. However, you need to modify it. So with a baby, you would give 5 initial rescue breaths first. So we want to get the oxygen in first. Now, with a baby, you're going to cover the nose and the mouth. And with a child, again, you're just going to think about your breathing rate. So for a baby, it's enough to blow a candle out. For a child, it's a half breath. And then for an adult, a nice deep breath. The chest compressions are done slightly different for, again, baby, child, and adult. For a baby, you're going to do 2 fingers and you're going to try and just push down for those 4 centimeters. And for a child, it's 1 hand and not 2. So again, the sequence can remain the same, but you're just going to be doing 2 fingers and 1 hand. So you've got the breakdown there of what that looks differently. So if you're on your own for a baby or an adult, you're going to do CPR first for a minute before you get help. So that's the early chain to survival. Okay, so we're just going to start that quickly. So again, CPR for a child. D, danger. R, response. Hello, can you hear me? Can you open your eyes? Open the airway. Look, listen and feel. Children and baby have 1 minute of CPR before we leave them on their own to call for an ambulance. But ideally, you're not going to leave them on their own because we all have mobile phones. But if we were, we would do that. We're going to call for the ambulance and AED. And again, for children, we're going to give 5 initial rescue breaths. Once those initial rescue breaths are done, we then go back into 30 to 2. Okay, so for children and babies, we go through the sequence. If they're not breathing, we give 5 initial rescue breaths first, then we do the chest compressions, and then we go 30 to 2, 30 to 2, 30 to 2. So let's talk about vomiting during resuscitation. So gurgling noise when you're giving a rescue breath may mean that you've blown too hard into the mouth. The overflow of the breath has filled the lungs up and it's gone into the stomach. It churns it up and either it can projectile out to you. But again, you're going to just tip the casualty onto the side and drain it away. Obviously, you need to minimize the disruption to your CPR sequence. So you need to get that drained away as quickly as possible. So turn them on their side, scoop it out, go back. When we're dealing with an unconscious casualty and we're talking about the airway, here you can see the head is just in a normal back position and the muscles at the back of the throat and the tongue is just falling back on the esophagus, blocking the airway. Equally, what will happen then with the vomit just sits there and obviously can block the airway. So it's really important that we tip them over. Now, we have a thing called fish-shaped, which is causes of unconsciousness. And for causes of unconsciousness, we're now dealing with our airways. We've done our we've done our danger response, we've done our airways, we've done breathing. They're breathing, but they're still unresponsive. Okay, so at this point, we've done airways, we've done breathing, but they are breathing. So we did alert, voice, pain, unresponsive. They're unresponsive, so they're unconscious. Okay, alert, voice, pain gives you the score of unresponsive. So at this point, we're going to do what's called fish-shaped. And this gives you the reasons why we can go unconscious. So going back to your assessing the scene, thinking about what's going on. So the first one for fish-shaped is fainting. So we've got lack of oxygen, we've just gone down and we've hit the deck. Imbalance of heat, so too hot, too cold. Shock. So that's the medical shock, not the, ooh, my phone bill's really expensive, but the medical shock. So loss of bodily fluids. We've got a head injury, stroke, heart attack, asphyxiation, so can't breathe, poisoning, epilepsy, or diabetes. Okay, so these are our causes of unconsciousness. The acronym is known as fish-shaped, and it's been like that for quite a long time. So we'll cover that again. Fainting, imbalance of heat, shock, head injury, stroke, heart attack, asphyxia, poisoning, epilepsy and diabetes. So these are the things why somebody is going to be on the floor and unconscious. We've talked about levels of unconsciousness already. So hello, can you hear me? Can you open your eyes? So after we've done the danger and we're hitting response, this is the levels of response. It's known as AVPU. So hopefully we've all sitting there now going, Steve, we know what that is. You've told us. Alert. So hopefully that's where you all are at the moment. I haven't sent you into levels of unconsciousness. Voice. Do you respond to my voice? Hello, can you hear me? Can you open your eyes? Pain. Pinch the ear, flick the eyelash. If not, you are unresponsive. So this is the same scoring on the news and muse. So this isn't new to you. This is the same scoring on vital signs. Now, if somebody is unconscious, we're going to place them in the recovery position. So the hand goes into the how positions. The hand closest to us goes up to how, so we wave. And the reason we do that, we can now move in towards the body and we can produce, we can move the body as we need to. The arm opposite comes up and over to touch the cheek. So we're now in that position. Now, if they're wearing rings, we're going to turn the rings around, the stones are facing upwards, not causing further injury. We're going to bring the furthest knee, so it's elbow to knee. So we've got like that Twin Peaks thing going on. We're going to bring that knee up and we're simply just going to then roll them onto our side. Now, once they're on the side, you can see in this picture in the right-hand corner, we need to bring that knee up to a 90-degree angle. So it keeps us balanced. We need to make sure the head is on the hand. So if he's sick, it drains away. And we need to make sure that they are still breathing. So the recovery position for a baby, very similar, but we're just going to do it all in our arms. We're going to tilt the baby towards us. We're going to put the head cradled down and we're going to lower the head just slightly and lift the bum up just a little bit, supporting so the baby can breathe quite easily on their side. So, some do's here. Do turn the casualty on the opposite side every 30 minutes if they're in recovery positions prolonged. So, place a heavily pregnant casualty on the left side to help circulation. Do not place a pillow or anything under their mouth, and do not place anything in the casualty's mouth. So we talked about causes of unconsciousness and we went into epilepsy, and epilepsy looks at focal seizures. So focal seizures is where we have a signal in the brain and it's at one particular point. Now you've already done your epilepsy training, so you're going to know this. To generalized seizure, that then means it moves all over. So focal, one area, generalized, all over. For a seizure, we know that we're going to leave the casualty laying down. We're going to allow them to have the seizure. And at this point, we could place something under the back of their head to stop the head banging on the floor. But we do not hold the casualty down. So when we think about the respiratory system, and again, through our anatomy and physiology, so you're going to know all of this anyway, we've got our nasal cavity, which is a route into the mouth. We obviously have our mouth cavity, which connects to the back, and our tongue. We've got our epiglottis going into our larynx and our esophagus down to the trachea. And then as we move down, we've got our bronchial lungs. So we're going to move to the lungs. And as we go in there, it kind of starts to sprout out like cauliflower and a tree. So there are bronchiolites, and we've got the alveoli bits down at the bottom. So what tends to happen with asthma, and again, you'll see this in a minute, asthma, they don't contract and extract and contract properly. And with pneumonia, it starts to fill up with liquid at the bottom of the lungs. So we know that our lungs should be dry. and any fluid in the lungs can cause pneumonia. So we know that. One does then beg the question about vaping. How is vaping safe when we're inhaling that moisture in? So not that we're lecturing smokers. And again, we've got our diaphragm, and obviously if our diaphragm's broken, we've got a problem there, because that's what creates the vacuum to breathe in and out. It's important that we understand a little bit about how the lungs work, because again, if you've got a lung injury or a collapsed lung, you need to obviously, if one lung is filling up with fluid, you need to lean them on the opposite side so it doesn't fall into the other lung and cause a problem. We know through our air exchange, we've got our bronchial tubes there, we've got our capillaries and our alveoli, so that's the sprouty bits going around, and we've got oxygen going in one side and carbon dioxide coming out the other, and that's how our air exchange works. And what we've got to make sure is that air exchange is working well, and we've covered this in vital signs, so we know that we should be breathing at least 95% oxygen in. Anything else is going to cause us a problem, so either having too much oxygen or not enough oxygen. So life-threatening conditions then could be around choking. So within your homes, if you have people that are at risk of choking, there are choking packs now which you can buy, and basically it's like a face mask, and it's got a pump on the top. You pop it on and it sucks out whatever's being blocking the airway. So if you are working in a nursing and residential home, you must learn how to use these. It's far more superior than doing first aid unnecessarily, because you know your people are at risk of choking. But anyway, signs and symptoms of choking. First of all, ask, are you choking? People know if they are. Mild choking can cough and answer questions because the airway isn't completely blocked. Severe choking is they've got a weakened cough, they're unable to speak, they're going to be struggling, they're going to look distressed, and they will become unconscious if untreated. So, can you cough? We're going to do 5 back slaps, and we then go into the abdominal thrust. So, as we do the back slap, we're going to put our arm around their chest, we're going to support them, and we're going to pat them 5 times. If nothing has come up, we go to the abdominal thrust. So we're going to go into the abdomen, we're going to push in and up, sharp 5 times, and we follow that sequence, okay? So back slaps, abdominal thrust. Now, if you do 1 abdominal thrust, you must get an ambulance. For a baby, you're going to place the baby's face into your hand, you're going to kneel down and lean the baby along the arm, and you're going to pat the back. And then for a chest thrust, you're going to turn them over onto your arm, and you're going to push down on the chest like a chest compression, and you're going to do 5 chest thrusts. And again, we just repeat that sequence until it has been removed. If it hasn't been removed, we're going to go into our unconscious casualty situation, and we're going to start CPR. And what is hoped is through the chest compressions, it will come out, or at least through the rescue breaths going in, you could push it in. Seeking medical advice. So after successfully treating, seeking medical attention if the casualty has received any abdominal thrusts. They've still got a problem with swallowing, so it may be that they've damaged their throat muscles, and that's going to cause it to swell, and that could cause a problem with breathing. If they have a persistent cough, or if it feels like the object is still stuck in their throat. So we'll now move on to blood loss and shock. So we have here are blood vessels, which obviously are responsible for traveling the blood through our cardiac system. And there we should have a normal heart rate between 60 and 80 beats a minute. So if it starts to go up, we've got a problem. And then blood pressure, we know it should be about 120 is the average, but from a clinical point, we're not that worried between 111 and 219 from a Muse score point. So that's from our Muse scoring. But again, with blood loss, the blood pressure will drop. So blood vessels will obviously contract, go small, heart rate's going to start to go up, and blood pressure starts to drop. So here, it gives you an idea of what that looks like. So if we look at 10% blood loss, we've got a normal look. We may just feel slightly dizzy when we stand up. Our lower levels of consciousness and restless and being slightly a bit anxious, or we become unresponsive. Skin, again, normal, pale, cyanosis, that blue, and severe cyanosis, which is cold and blue. 10%, we've got our pulse, slightly raised for 20%, 30% blood loss, it becomes rapid, and then it becomes undetectable. And then breathing, again, normal, slightly raised, rapid, and breathing slightly like hungry for air. So again, looking as you go across, you can see what blood loss may look like. 3 types of wounds in which or 3 types of bleeds in which we need to be aware of. So this is where your wound management bit will come in after we've done the session, and we look at the wound management here. 3 types of bleed. We've got our arterial bleed, venous bleed, and a capillary bleed. And you must know the difference between the 3. So this one here looks to me like an arterial bleed, because it's projectiling and it's pumping at the beat of the heart. So it means it's fresh oxygenated blood, it's coming out and it's pumping. So here you can see it's spurting. When it's a venous bleed, it just oozes, and capillary, it just trickles, okay? So if it's spurting out, we've got an arterial bleed. If it's oozing, so imagine that wasn't spurting, that would then be definitely oozing, that would be a venous. And then if it's just trickling, you have capillary. Now, for the skin, for the body to go into shock, it's normally when we lose bodily fluids. So this is when the heart is pumping fine, there is enough blood in the blood vessels, and the vessels have a good tone, okay? When blood fluid is lost, we go into hypothalamic shock, so that's obviously where we're losing our blood, and then here we need to manage that situation quite quickly. So in the cardiac system, we need the whole torso of our body. So imagine this is our heart, and as we go up, we've got our head and lungs. We need to keep the blood from legs up, because that's where all of our vital organs are. So here, if we start to lose blood pressure, so we're going to the hypothalamic shock, so we're losing that blood pressure, blood's now not getting to our brains, so it makes sense that the treatment then is we sit or lay the casualty down. So I always go for lay the casualty down, because if you sit them, they still have got a place to fall. You can't fall from the ground. So my rule is get them on the floor, examine them, and then treat the blood, rapidly assess, make sure you know the types of blood, find where it's bleeding, look for the orange foreign objects, and treat for shock. So deal with that, so lift their legs up. Now, treatment for bleeding is sit or lay the casualty, examine and apply pressure. So you've got SEEP, S-E-P, sit, examine, pressure, or you can have RED, which is rest, elevate, direct pressure. So you can choose either of those as your acronyms. Sit, examine, pressure, or think RED, rest, elevate, direct pressure. Now, the reality is you don't need to be doing anything at this point. They can lift their arm up, they can apply their own direct pressure, and we can take it from there. So pressure should be for about 10 minutes, and obviously then look in at dressing. So catastrophic bleeding on prioritising treatments. So here, catastrophic bleeding, we need to prioritise over everything else, because obviously if we've got no blood in the body, we can't pump and we can't, there's points in CPR. We'll then deal with airways, breathings and circulation. So other issues around life-threatening conditions with bleeding is you can't control the bleed by sitting the patient down. So you've put the dressing on, it's still bleeding, you've done direct pressure and it's still not worked. So therefore, we need to go for indirect pressure. So for indirect pressure, we can use the neck, abdomen, groin, or armpit. If possible, apply pressure to the exact point of the bleeding, but if not, go for indirect pressure. So again, you can squeeze down here and that will stop any bleed on the arterial. In the groin, you can separate the groin and put your foot in between the groin. And again, under the armpit, you can push under there to try and stop any indirect bleed. What we need to do is tightly pack the whole of the wound, and we need to compress for 5 minutes, and we need to repeat if needed. And then here we send package into the hospital with a casualty. Do not block the airflow if somebody gets stuck in the chest. So again, if you've got a direct knife injury or something, we leave the foreign objects in the body. So if they've got a knife in them, we would leave that knife, we would pack around it, and obviously we would try to do indirect pressure. So again, looking at wound management, indirect pressure as much as you can. And there's some training on there. So if you're going to use that packing that goes into the wounds and helps to stem the flow, that's what we've got. Tourniquets, for life-threatening bleedings that cannot be controlled by direct pressure. We've got arms, limbs, and multiple traumas and multiple casualties. So here, if you had to apply a tourniquet, so indirect pressure, we can apply the tourniquet, but you must keep an eye on the time of the tourniquet. And that's because if we cut the circulation off to the limb, the problem that we've got is there is now no blood going to the limb. So in this first one, you can see the skin above the tourniquet is nice and healthy. The skin below that tourniquet is already started to go white. And the problem is, if we're not getting oxygen to those areas, then the limb will die and we're going to cause further complications. So again, it's really important that you think about how you're going to do that. Ultimately, we would always hold, and if you can hold the tourniquet there, so if you're applying the direct pressure, it means that you can release a little bit of blood back to the injured site just to keep the limb alive and then just reapply. So you must make sure that if you are applying a tourniquet and you can see the limb starting to go blue, you can gently release, get the blood flow back and then reapply that direct pressure or indirect pressure. So here you can see they've done an improvised tourniquet, but again, you can just tie something up. It's just a case of whatever you're putting on there, you need to make sure that your tourniquets are safe. And again, there's a couple of videos there on how to apply tourniquets. Other types of bleed are your contusions. So that's a bruise. So if we've got a bruise, we've got a bit of bleeding under the skin. An abrasion, so this is where we've got a graze, the first layer off. We then have a laceration. So that's where it looks like it's been chunked. So there's no neat bit there. It's just completely torn apart. The incision, so that's a nice slice. We then have the penetrating, so that's the puncture, so that's a hole. Okay, sorry about that picture. So we've got our hole. And then finally, we've got the amputation, and that's where it's completely been severed and we need to deal with both parts. If you've obviously got the amputation, we wrap it in a cotton, non-fluffy, sterile, so a triangular bandage, pop it in there, pop it in a bag, make sure you put their name on the bag so they know whose limb that is, and then again, try to pack that in ice. Embedded objects or foreign objects, we're going to leave where they are. We don't touch those. We pack up and around, and again, indirect pressure. So things that you can treat are mine splinters. So again, we can run those underwater, encourage them to come out, use and pull in the direction that you want to come out, squeeze to remove any excess, and then obviously think about tetanus and getting any further medical things. Insect bees, so insect stings, again, thinking about anaphylaxis or animal bites. Again, we would treat as we do, so we can apply the dressings on, and again, think about tetanus and all that lot. Nosebleeds, just tilt the head forward, get them to pinch the nose. And then eye irrigation, so anything in the eye, we're going to tip under cold running water and to rinse away from the other eye. So again, that's a great way of dealing with that. So burns, moving on to burns. We've got the severity of a burn, and here it's got scald. So here we've got the size of the burn, the cause of the burn, the age of the person, the location of the burn, and the depth of a burn. Okay. So size. So we have what's called the rule of 9. The hand's known as 1%, and then the arm is known as 9%. So if we're burning over a certain percentage, and again, I'll explain this shortly, you'll know when to get treatment. So here, we then look at the depth of the burn. So the epidermis is the top layer. The dermis is the tissuey bit underneath that you can start to see, and the subcutaneous level when it goes to the yellow. So here you've got what that burn looks like on all three. So starting at the top, the epidermis is the reddened area. The dermis is where you can see it splitting up, going down, and subcutaneous. And we call those first, second, or third degree superficial, full thickness, or superficial, partial thickness, or full thickness. So superficial is at the top, first degree. Second degree burn is at your dermis, partial, and full thickness is when it goes to the subcutaneous level. There we go, superficial, partial thickness, and full thickness. So that gives you an idea of what you're dealing with. So the rule of 9, as we said, 1% counts to the hand or the groin, and everywhere else counts as 9. So 1% burn, full thickness, must go to hospital. So actually, it doesn't matter the size of a full thickness burn, you must go to the hospital. Okay. Superficial burns, so normally the rule of 9, so if it's covered more than 9% of the body, that's off to hospital. And if it blisters and the blister is bigger than the size of your hand, that's off to hospital. So if it's a reddened area the size of your chest, that's off to hospital. If it's a red area, if it blisters up and the blister is the size of your hand, that's 1%, their hand, that's off to hospital. Okay. Always go to hospital if you're worried anyway. So treatments of burns, cool the injury down, remove any items that you can, if you can remove them. If you can't, obviously leave it, and then you can dress the burn. So think about infection control. So lightly wrap it in cling film, but allow for the swelling. Okay, moving on to the skeleton system. So again, you've covered this in your anatomy and physiology. So you've got your skeleton here, looking at your skull, moving down to your clavicle, scapula, sternum, ribs, humerus, vertebrae, ulna, radius, exactly. Just keep going. So again, you don't need to know all of this in Latin. We never, in all the years that I've worked, I've never gone, you know, there's injuries to the phalanges or the patella. I've gone, the kneecap's got a problem, or there's a problem on the left finger, or, you know, it's the right shoulder or the right shoulder blade. You are expected to know it from a nursing point, but we never talk in that way. So we've got types of fractures. So here we've got a closed fracture. So a closed fracture is where the skin's still intact, but the bone has just snapped. An open fracture is the bone's separated and it's protruding through, and you can see that it's come through, so you'll see a bleed. A complicated fracture, and these are really dangerous, is where the arterial system's got caught up in the bone. And obviously if that moves, you could sever the artery and then cause internal bleed. And then green stick, common in young or older people, is where the bone snaps, but it doesn't snap fully. Now, ultimately, you're not going to really know a great deal just by looking, but this is what a closed fracture looks like. It's slightly out of shape. It looks a bit awkward. It's not so great. Open fractures, just be ready. So that's where you've obviously got the bleed and you can see the bone. Okay, so that's your open fractures. I mean, that's quite funny that it's got please note the poor aseptic techniques. I mean, at this point, you know, it's going to be down to the hospital to manage that. We're just going to be worried about the indirect pressure, because you can't apply direct pressure to that. So we're going to go indirect pressure at the top of the groin, and we could obviously then wrap that. But that's going to be very painful. They're not going to let you, again, you touching this is, they're going to be screaming in agony. This is going to be very, very painful. So again, you can only do what you can do. So again, it very well could be indirect pressure to just stem the bleed, and obviously call for your help. So dislocations, when the ball or socket or the joint has come out, so you can normally see those. So dislocated and normal, just so you've got something to compare to. And then the signs and symptoms: pain at the site, loss of power, unnatural movement, swelling or bruising, disformity, irregularities, crepitus. So crepitus is this. So the bones grinding against each other, and very tender to touch. Now, if you're able to treat any of these, you could do the elevated arm sling. So this is where you bring the arm up across the chest, pop the triangular bandage over, tuck it up and under behind, and then tighten up. Alternatively, you could just use the jumper. So the support sling, which is the lower arm sling, we go up and under and then around. So that's just the support sling. So the spine, we have, it's made up into our three parts. And here we're just looking at what could be the cause to a spinal injury. Here we've got a blow to the back of the head or neck, fall from a height, drive, so an incident or an accident, a cave-in accident, I've not heard of those ones, multiple injuries or pain or tiredness to the back or neck. If in doubt, you're going to keep somebody still, and you can help mobilize the neck. And signs that you're going to be looking for spinal injury could be clear fluids coming out of the ear, nose, or any of the orifices. But obviously, you need to make sure that you're maintaining that they're still. Okay, moving into diabetes now. So here we're looking at maintaining blood sugars. You've already done this training. So again, just to recap, we've got high and low blood sugars. We know if it's below 4, that's a problem, that's hypo. Our normal is between 4 and 7, and then our high is 7 and above. So for us, it's all about balancing the sugar and the insulin, making sure that you've got a fixed amount of insulin that burns up the sugar. And obviously the insulin there is to balance that. So if it's left untreated, we have too much sugar and not enough insulin, making them go high, and then vice versa, too much insulin and not enough sugar makes you go low. So why is low blood sugar so dangerous? And that's because So being hypoglycemic is much more dangerous, and that's because the brain cells can only use glucose, sugar, for energy. So we need oxygen, we need food, that equals energy, and energy equals life. So if we're too low in sugar, we can give them 20 grams of glucose or 150 mils of Lucozade, a can of lemonade, 200 mils of orange juice, 4 jelly babies, or 4 spoonfuls of sugar, or 20 Skittles. So all of the stuff that's super sugar. Just be mindful that from an emergency point of view, this will get them out of the problem that they're in. But if we give a sugar intake, a sugar rush, then you can get a sugar drop. So, because again, these are artificial, these aren't the great sugars. Okay. And equally, we know at that point we should be doing our glucose tests if we're in a nursing situation, recording that, and then following the care plan on giving insulin dependent upon what the care plan says. Okay. So the heart, we've got, obviously, for the heart, we've got the blood coming in that goes up to the lungs. We've got our oxygen and deoxygenated, so coming in, coming out. And we've got our left aorta and our right aorta, and here red for oxygenated, blue for deoxygenated. So again, looking at kind of how that works regarding any conditions such as heart attacks or cardiac problems. Angina is where the arterial walls of the coronary artery wall becomes thicker, and that's because either cholesterol plaques or something's pushing that artery together and reducing the blood flow, and that causes angina. So it feels like a heart attack. Equally, the heart attack is where you've had a slight tear or a bleed. The bleed causes a blood clot. The blood clot blocks the artery, and obviously it causes the heart to not pass the oxygenated blood around the body, causing the arrhythmias and all of that lot, and obviously causes the heart attack. So the difference between angina and heart attack: onset for angina, sudden, usually during excursion, stress, or extreme weather. Heart attack can happen during rest. The pain for angina can feel like squashing, dull, thickness, pressure, could be mistaken for indigestion. Same though for heart attacks, so very similar. Location of the pain is at the center, arm, neck, jaw, back and shoulder, the same. Duration between 3 and 8 minutes, rarely longer. Heart attack longer than 30 minutes. Skin can go pale and maybe sweaty. Heart attack can be pale grey and sweaty. Pulse can become irregular and miss beats. Again, same for heart attack. Other symptoms: shortness of breath, weak anxiety. For heart attack, shortness of breath, dizzy and nausea, vomiting, sense of impending doom. Factors giving relief: rest, reduce stress, take the GTN medicines. And again, for heart attack, they may have their GTN medicines can be given. Stroke, you covered stroke again the other day in the other session. So here we're looking at a bleed on the brain. Again, same thing, slight bleed, blocks the brain and causes the stroke. Here we use the acronym FAST, so we're looking for facial weakness. We're looking for arm weakness, the arm dropping. We're looking for speech problems, so starting to slur. And then we do time to call 999. Asthma, so looking at respiratory conditions. We spoke about this at the beginning. We've got our normal airways and the muscles around the alveoli and the bronchial tubes. This is where they thicken up and they narrow, and that inflammation thickens and narrows the airway, and that's what that wheezing is. Signs and symptoms for asthma: difficulties in breathing, wheezing, breath sounds like it's from the lungs, difficulty in speaking, trying to get those sentences out, could be pale, cold and clammy, grey or blue lips, so the cyanosis, lack of oxygen, use of muscles in the neck and upper chest, and again, depends on the severity of the attack, they may become unconscious or stop breathing. So treatment then. Silencing asthma is not good, it's deadly. So do keep the casualty upright, use a spacer device if possible. And the spacer just makes it easier to take the medication in. Do not lie the casualty down, do not take them outside in cold air. Do not equally give them brown paper bags and allow them to manage it by themselves. Normally people with asthma will sit forward, they'll get themselves into a nice comfortable position. And again, you may need to get ready to use a nebulizer and steroids to help manage that. So anaphylactic shock. So here we can see severe swelling. So this is a massive allergic reaction. We've got hives down the neck and all that blanching and rashes. And then we've got the oedemas and the swelling around the eye. This poor old lad, he's been used since 1990. So he's been around a while, this lad. So you can, again, here you can see the swelling of the lips and the blanching there. So anaphylactic shocks have three characteristics: a rapid onset, so the casualty becomes unwell very quickly; life-threatening, so airways and breathing and circulation problems become difficult; and the rash followed by swelling will become apparent. So we need to maintain airways, swelling of the tongue, lips and throat, a feeling of the throat closing up, or hoarseness of voice or breathing. Breathing becomes difficulty, wheezing and tight chest. And then circulation, they can feel dizzy, pain, cold, clammy, rash may disappear, nausea, vomiting and diarrhea. All of this, if they suffer anaphylaxis, they should have an EpiPen. And you can see on these pens, they all have the directions on what to do. So again, remove any of the outer packaging, shake it, and here you can see that you can go through the outer clothes, and some of them you need to go on directly to bare skin. But it's about getting that adrenaline into them as quickly as possible. So during the HSC, so the regulators for first aid, so the Health and Safety Executive, describe what training people must have for first aid. So what they state is everyone should do an emergency first aid at work course, which is a one-day course, minimum of 6 hours. You do the first aid at work course 3-day. And down here, it shows you the syllabus of what's covered on there. The first aid at work refresher course is a 2-day, and the annual refresher is a 3-hour course. Okay, and in those 3-hour courses, you're looking at safety action plans, CPR, treating unconscious casualties, wounds and bleeding, and shock. The HSE first aid course sequence of training. So you can see there, you do a first aid needs assessment, decide what one you need. So do you need the first aid at work or the annual one? You then do your annual refreshers yearly. And then here you go into your full refreshers and your annual ones, just doing your additional training. So hopefully successful resuscitation is where we need to be. Once we've done that, we're going to fill out our incident and accident reports, be that either the tear off pads for GDPR or our online systems. We'll do names and addresses. We're going to fill in about ourselves. We look at the incident accidents and if we're going to report to RIDDOR. Now, that was a real quick overview of the emergency first aid at work, just touching on lots of all of the other stuff that we've already done throughout this. You will be observed doing CPR. You will be observed doing the recovery position. You will be observed dealing with the bleed, and you will have to talk to me about how to treat asthma, diabetes, and all of those other health conditions in which you've covered through this qualification anyway. Hopefully you found that useful as a quick overview. This is only the knowledge part to the training. You still must do the CPR and the recovery and the practical session as well. So this only runs in line with the theory requirements for your training. You still must do the mandatory training that you obviously do through your employer as well. So this does not exempt you from that. You still must do your employer stuff. But also, it's just useful for you to have an update as part of your assistant practitioner program. And for the basic life support, this covers the sufficient knowledge and understanding for your basic life support. So hopefully you found that useful. We are going to look at other things now, such as dressing wounds, looking at dressing wounds. You're going to be doing other conditions around the respiratory, and you'll also be doing pressure care and stuff. So thanks for watching, and I will see you